Hello everyone, welcome back to the GSM MedMint for those who breathe medicine. Today we are mastering the pulmonary function tests. A patient comes with the progressive dyspnea, you order the pulmonary function test. The FEV1 is 65% predicted. Your senior says that FEV1 is low, so start bronchodilators. This is obstructive. But FEV1 alone means nothing. The ratio is everything. If FEV1 over FVC is normal, this is restrictive lung disease. The bronchodilators are of no use here. He needs a high resolution CT scan plus possible antifibrotics. The topic is restrictive versus the obstructive lung disease. Two patterns, three numbers, and one correct diagnosis. So let's dive in. Picture this, a 62-year-old with progressive dyspnea. Over the 6 months, you order pulmonary function tests. The report comes back, the FEV1 is 65% predicted. The FVC is 70% predicted. The FEV1 over FVC ratio is 72%. Your senior looks at the FEV1 and says, this is low, this is obstructive, start albuterol and tiotropium, the bronchodilators. But look at the ratio, the FEV1 over FVC is 72%, which is normal. The problem is not the airways. The problem is the volume. This is a restrictive disease. The interstitial lung disease, bronchodilators are useless here. The patient needs a high resolution CT of the chest and possible antifibrotics, not albuterol. The rule is simple. Stop guessing based on the symptoms. Read the pulmonary function test like a pulmonologist. Three primary parameters, the FEV1 over FVC, the TLC and DLCO. These tell you everything. So before we decode the matrix, let's review the basics. What is spirometry? The spirometry is measure how much air you can exhale, how fast you can do it. So how much air you can exhale and how fast. The FEV1, the forced expiratory volume in the 1 second. This is the volume of air exhaled in first second of the maximal forced breath. It measures how fast the air moves out. It reflects the airway patency. It reflects the patency of the airway and the airways are open or blocked. The FVC, the forced vital capacity, this is the total volume of air exhaled after a maximal inspiration. It measures the size of the lung, how big it is and how much total capacity is there. The FEV1 over FVC ratio, this is the proportion of the total lung volume exhaled in 1 second. Normal is greater than 70% or greater than the lower limit of the normal, which adjusts for the age, sex, height, and ethnicity. If the ratio is less than 70%, if ratio is less than 70%, this means obstruction and the patient cannot get out the air fast. The airways are narrowed or collapsed. If the ratio is normal or greater than 70%, greater than or equal to 70%, this means no obstruction, the airways are fine. If the FVC is also low, if FVC is also low, the problem is restriction. The lung is small, the patient cannot get in the air fully. The obstructive lung disease, the concept is simple. The air cannot get out. The pathophysiology, an airway narrowing or collapse. The airways are blocked, inflamed, or have lost the elastic recoil. In emphysema, the alveolar walls are destroyed. The tethering that holds the airways open is gone. They collapse during the expiration. In chronic bronchitis, the airways are inflamed and narrowed by the mucus. And in asthma, smooth muscles bronchospasm narrows the airways. The result is air trapping. The air gets in. During the inspiration, the air is held open by the negative intrathoracic pressure, but during the expiration, the positive pressure collapses the diseased airways. The air gets trapped. The lungs overinflate, the diaphragm flattens, the chest becomes barrel shaped. So, what happens to the numbers? The FEV1 falls a lot. So the patient cannot blow out fast. The FVC falls some. The air trapping limits how much they can fully exhale, but FEV1 falls more than the FVC. So the FEV1 over FVC ratio, this drops. It is low, less than the 70%. The FEV1 over FVC ratio is less than 70%. This is the hallmark of obstruction. The flow volume loop shows the classic baby carriage or scooped shape, which we will encounter later. The expiratory limb is concave, scooped downward. The peak flow is reduced. The tail of the loop drags on forever because the air trapping prevents the patient from returning to the zero volume. So, this is the picture of obstruction. So now, not all the obstructions look the same on the PFTs. Let's break it down. COPD, the emphysema plus the chronic bronchitis, the FEV1 over FVC is less than 70%. The FEV1 is reduced. The TLC may be normal or even elevated due to the air trapping. The DLCO is low in emphysema because the alveoli are destroyed here. So the surface area is less for the gas exchange, but DLCO is normal in chronic bronchitis. Why? Because the problem is the airways, not the alveoli. So chronic bronchitis, airway problem, and the emphysema, the problem is the alveoli. The asthma, FEV1 over FVC is less than 70% during an attack. But this is reversible. Give the albuterol and repeat the spirometry within the 15 minutes. A positive bronchodilator response is defined as the FEV1 increasing by at least 12% and at least 200 milliliters from the baseline. If you see this, it's asthma. The TLC, the total lung capacity, is normal. The DLCO is normal here. Again, because the problem is the airways. So, there is no structural damage. The problem is bronchospasm. The bronchoectasis, the FEV1 over FVC less than 70%. Often this is mixed, not the fully reversible with bronchodilators. The DLCO is usually normal unless the disease has been advanced. So in obstruction, the TLC can be normal or even it can be elevated. It is never low. If you see the low TLC in a patient and you thought had COPD, so you should stop. You should reconsider. This might be a mixed disease, or you might be wrong about the diagnosis. The restrictive lung disease, the opposite problem. The lung cannot get full. The pathophysiology behind the restrictive lung disease is that lung volume is reduced. So the lungs are stiff, scarred, compressed, and the respiratory muscles are weak muscles. Patient cannot inflate the lungs fully. Compliance is reduced and it takes more pressure to expand the lung. This can be intrinsic. The lung parenchyma itself is diseased. The interstitial lung disease, idiopathic pulmonary fibrosis, sarcoidosis, hypersensitivity pneumonitis, connective tissue disease related to interstitial lung diseases. The alveolar walls are thickened by the fibrosis or inflammation. The lung becomes stiff and small, or it can be extrinsic type. So this can be intrinsic or extrinsic. The lung is fine in extrinsic, but something outside is compressing it or preventing the expansion. For example, the chest wall deformity like kyphoscoliosis, the obesity compressing the abdomen or the chest wall, the large pleural effusion, neuromuscular disease like ALS or myasthenia gravis. The muscles can't generate enough of the negative pressure to inflate the lung. So what happens to the numbers? The FEV1 falls. So what happens to the numbers? The FEV1 falls, the FVC falls even more, the total capacity is reduced, but both fall proportionately. So the FEV1 over FVC ratio is normal. So FEV1 by FVC ratio stays near normal and can even be high. The problem is not speed, it is the size. The lung is small here. So the speed is not problem, the lung is small. The flow volume loop shows the miniature or shifted shape. The entire loop is smaller in all dimensions, but the shape is preserved. So it is not scooped like in the obstructive pathology. It is just miniaturized. So the expiratory limb is short. So it is short but not concave. This is the picture of restriction. Again, let's separate the intrinsic from the extrinsic restriction. This is where the DLCO becomes our friend. So intrinsic restriction is the parenchymal lung disease. For example, we stated earlier, idiopathic lung disease, the pulmonary fibrosis, idiopathic sarcoidosis, hypersensitivity, pneumonitis, connective tissue diseases related to interstitial lung disease. So radiation pneumonitis, the alveolar membrane is destroyed, the main key point. The alveolar membrane is destroyed and the PFT pattern shows FEV1 over FVC normal or high. The TLC is less than 80% predicted. DLCO is low, often very low, even less than 60% of predicted. DLCO is the key because the gas exchange membrane is damaged, less surface area, thickened barrier. This is your diagnostic clue. Low TLC plus low DLCO equals to the intrinsic restriction. So low TLC plus low DLCO is equal to the intrinsic lung restriction. The extrinsic restriction, chest wall, pleura, neuromuscular, kyphoscoliosis, obesity, large pleural effusion, neuromuscular diseases, the lung parenchyma is completely normal. So the parenchyma is fine. In the extrinsic restriction, it just cannot expand. So the pulmonary function test pattern stays FEV1 over FVC. This is normal or high, same as the intrinsic one. The TLC is less than 80% of expected, and the DLCO here stays normal because the alveolar membranes are not destroyed. The parenchyma of the lung is normal. So the gas exchange membrane is intact. This is your clue. The low TLC plus normal DLCO. This implies the extrinsic lung restriction. The most important number after FEV1 over FVC ratio is TLC, and DLCO separates the intrinsic from the extrinsic restriction. So here is the step-by-step decision tree, the three numbers, the three steps. Step 1, we should look at the FEV1 over FVC ratio. It is less than 70% or less than the lower limit of the normal. If yes, this is obstruction. The airways are the problem. Airways. So if no, the ratio is normal or high, there is no obstruction, we should go to the step number 2. Step number 2, look at the TLC, total lung capacity. Is it less than 80% of the predicted percent? If yes, this is a restriction. So yes, restriction. Then the lung is small, you should go to the step number 3. If no, then the TLC is normal or high. This is not restriction. The PFTs may be normal, or there may be a mixed pattern, or the dyspnea is from something else. For example, the cardiac deconditioning anemia or some other pathology. Step number 3, look at the DLCO. It is low if yes, it is intrinsic restriction. The causes possible are the interstitial lung disease, pulmonary fibrosis, sarcoidosis, connective tissue disease, order a high resolution CT plus anti-fibrotics can be given. If the DLCO is normal, then it is extrinsic restriction, the chest wall, the neuromuscular obesity. Treat the underlying cause here. We need to treat underlying cause. Physical therapy, weight loss, neuronal refer we can do in this situation. So if you remember, one thing from this lecture is that FEV1 over FVC. So FEV1 over FVC, it tells you about the obstruction versus the restriction. No, okay, non-obstruction. The TLC tells you about restriction, and the DLCO tells you why there is the restriction. The three numbers, one diagnosis. So let's talk about the flow volume loops. This is the visual signature of each disease. Normal loop, symmetric, teardrop or triangle shape. Rapid rise to peak expiratory flow, smooth, linear decline back to zero volume. The inspiratory and expiratory limbs are the mirror images in the normal loop. The obstructive loop, baby carriage or scooped shape. The peak flow is reduced. The expiratory limb is concave. It scoops downwards. Why this happens? Because during the forced expiration, the positive intrathoracic pressure collapses. The diseased airways, the more forcefully the patient exhales, the more airway collapses, the flow drops, and the air is trapping, means the loop doesn't return to the baseline. There is a residual volume. There is a residual volume that is trapped in there, and in the inspiratory limb may also be flattened if there is fixed obstruction. Talking about the severe obstruction case, the loop looks like a half circle with the deep scoop. So the emphysema produces a very scooped loop or with increased total lung capacity. Asthma produces a scooped loop that normalizes after the bronchodilator. The main clinical pearl here is that the scoop tells you the obstruction, the size tells you the severity. A small and deeply scooped loop means that this is COPD. In the restrictive loop, completely different picture. In normal loop, we see the full sized teardrop. In the restrictive loop, we see the miniature or the shrunken teardrop. For example, the size gets small. The entire loop is small. Both height and width are reduced. The peak flow is reduced, but proportionately to the volume. The shape is preserved. It is just miniaturized. Why? Because it is because no because there is less lung volume to move, so the airways move fine. So the airways are fine. There is no collapse during the expiration. The problem is simple, that there is the less total capacity. The loop is shifted to the left and on the volume axis, and less total volume. This means that the x-axis is compressed. So the expiratory limb is short, not scooped. So the ratio of the height to width is preserved. If you scale up the restrictive loop, it would be normal. So this in the severe restriction loop, we see a tiny loop but still symmetric. It is not scooped. The interstitial lung disease provides a small loop with very low DLCO. The chest wall restriction produces a small loop with the normal DLCO. So in restriction, the loop is small. In the obstruction, the loop is scooped. The size versus the shape concept applies here. That is why the fundamental difference, if you see in the loop, you can make the diagnosis by reading a single number. So why the TLC, the number that confirms the restriction, why it matters? The total lung capacity is the total volume of the air in the lungs at the maximal inspiration. So it is measured by the body plethysmography or helium dilution, not by the spirometry. Spirometry gives you FEV1 and FVC. So to get the total lung capacity, you need full lung volumes. Why the TLC is essential? Because the FVC can be falsely low in severe obstruction. The FVC can be falsely low in the severe obstruction. In bad COPD, the air trapping prevents the patient from fully exhaling. The FVC looks low. The reader might think that low FVC, this is a restriction. But TLC is normal or high in obstruction because of the air trapping. The TLC is low in restriction, less than the 80% of predicted. The TLC separates the obstruction from restriction when the FVC is low. The low FVC plus the low TLC equals to the restriction. This is the key formula you should remember. So the low FVC plus normal or high TLC, this equals to the obstruction with air trapping. From this slide, the main clinical pulse stays this only. You should remember that low FVC plus low total lung capacity, this is restriction. So if you have only spirometry, no lung volumes, a normal FEV1 over FVC with low FVC suggests the restriction. But you cannot confirm it without the total lung capacity. Do not call it restriction without measuring the TLC. Order a plethysmography first and then you get a full picture. So the DLCO, the diffusing capacity of the lung for the carbon monoxide, the differentiator. It depends on the three things. So first of all, the DLCO measures how well the gas moves from the alveoli into the blood. So it depends on three things: the thickness of the alveolar membrane, number one, the surface area, the capillary blood volume. In the intrinsic restriction, the interstitial pulmonary fibrosis, sarcoidosis, etc., the DLCO is low, often very low, less than even 60% of the predicted. Why? Because the alveolar membrane is thickened by the fibrosis or the inflammation. The alveolar membrane gets thickened up, so the surface area is reduced. This is the diagnostic clue. The low TLC plus DLCO means the interstitial lung disease. So it means the restriction. You should order the high resolution CT scan and consider the antifibrotics. But in the extrinsic restriction, the chest wall neuromuscular obesity, the DLCO is often normal because the lung parenchyma is fine. There is some kind of problem to the lung parenchyma is completely fine. The problem is outside the lung. The gas exchange membrane is intact here. This is your clinical clue. The low TLC plus the normal DLCO. So the low TLC plus the normal DLCO, this indicates that this is extrinsic type of lung restriction disease. You should treat the underlying cause. First of all, physical therapy you should provide, weight loss, neuronal refer. So remember, in obstruction, the DLCO is low in emphysema because the alveoli is there. So if we talk about the obstruction, emphysema, the alveoli is there, they are destroyed. So the DLCO is low. The DLCO is normal in chronic bronchitis. Why? Because the problem is in airways. So the DLCO is low in an obstructive patient. So remember, if the DLCO is low in the obstructive patient, it tells you that there is some emphysematous component. So the DLCO is the most underutilized number in the pulmonary function test interpretation. It tells you whether the problem is in membrane, the airways, or outside the lung entirely. So always look for the DLCO. Now we talk about the bronchodilator response, the test that separates the asthma from the COPD. After the baseline spirometry give albuterol, so 4 puffs or nebulized albuterol, and wait for the 15 minutes, repeat the spirometry. The positive response is defined as the FEV1 increases by the 12% and the at least by 200 milliliters from the baseline. Both criteria must be met. So if positive, this is asthma. So this is asthma. The obstruction is reversible. It is the bronchospasm, not the structural damage. The management is inhaled corticosteroids, the long-acting beta agonist, and we should avoid the triggers. Allergens, immunotherapy, if indicated, the patient can be managed in outpatient with good control. Talking about the next, we have the negative test. Then this is the COPD or the fixed obstruction. The airways are structurally damaged. The bronchodilators provide the symptomatic relief but do not normalize the FEV1. So the management here is the long-acting muscarinic antagonist plus the long-acting beta agonist. The inhaled corticosteroids if frequent exacerbations are present. Smoking cessation is the most important intervention. Vaccines for the influenza, pneumococcal, pulmonary rehab. A significant bronchodilator response in COPD does not mean that it is asthma. Some reversibility can occur in COPD, but full reversibility, FEV1 returns to normal or near normal, suggests the asthma. The degree of the degree of reversibility matters in the case. Degree of reversibility matters. So now an important question. Can the patient have both obstruction and restriction? Yes, and it is more common than you think because combined pulmonary fibrosis with emphysema, CPFE, this is increasingly recognized, especially in smokers. So the upper lobes have emphysema, the lower lobes have fibrosis. So combined upper lobes have no emphysema, and the lower lobes have fibrosis. The PFT shows the both obstructive and restrictive features. The FEV1 over FVC is less than 70% and TLC is less than 80%. So both criteria are met here. So the both criteria are met here. So the obesity plus COPD, obesity plus extrinsic restriction depends. The COPD causes the obstruction here. Together they produce the mixed pattern. The FVC is very low because both diseases reduce it. So the flow volume loop shows both scooped and the miniature features. The challenges are the number that can be confusing. So FVC is very low, the ratio is low. The TLC is low and the DLCO is very low. So it looks bad, but it looks bad and it is bad. So these patients have significant morbidity and mortality. The management comes like we should treat both the components with bronchodilators for obstructive component and weight loss, physical therapy, positive pressure ventilation for the restrictive component. And you should refer to the pulmonology for complex cases and do not try to manage the severe mixed disease alone. So the both mixed type of pathology do exist. Obesity causes the extrinsic restriction. Excess adipose tissue in the abdomen of the chest wall compresses the chest wall. No, it compresses the thorax. The diaphragm is pushed upward, and the functional reserve capacity is reduced. So the expiratory reserve volume is the first to be reduced, and then the TLC may be mildly reduced and or at the lower limit of the normal in the severe obesity. The pulmonary function test pattern, the FEV1 over FVC, is normal or slightly elevated. The TLC may be normal or mildly low in this case, and the less than 80% in the severe obesity, of course, but DLCO is normal here. The lung parenchyma is fine. So the FRC and ERV are low. These are the first volumes to get affected by the obesity. Do not overcall the restriction in obesity because mildly low TLC in the obese patient may be completely physiologic. So look for the symptoms out of proportion to body mass index. If DLCO is also low, then think the concurrent interstitial lung disease, think the concurrent interstitial lung disease, not just obesity. If the patient has dyspnea disproportionate to the BMI, or if there are crackles on exam or clubbing, and these red flags are there for the intrinsic lung disease, do not blame everything on the weight. The treatment is the weight loss, the most effective intervention for the obesity related restrictions, and even the modest weight loss can improve the lung ventilation. So upper airway obstruction, we talk about the pattern, the PFT pattern that mimics the lower airway obstruction is completely different. The fixed upper way obstruction, the tracheal stenosis, laryngeal goiter compressing the trachea, mediastinal tumor, the obstruction is above the thorax. So it affects the both inspiration and the expiration equally. The flow volume loop shows the flattened or box shape in this case, and the both inspiratory and expiratory limbs are affected. The peak inspiratory flow is reduced, the peak expiratory flow is reduced, and the loop is looking like a rectangle or a box. This is completely different from COPD where the expiratory limb is scooped And the variable extrathoracic obstruction, like the vocal cords dysfunction, the vocal cords adduct during the inspiration, narrowing of the glottis, the inspiratory limb is flattened, and you hear the stridor on inspiration. The expiratory limb is normal. The cutoff is the inspiratory side only. It's on the inspiratory side only. So the variable intrathoracic obstruction, like we talk about tracheomalacia or the trachea collapse. The trachea collapses in this case during the expiration when the intrathoracic pressure is positive. So the expiratory limb is flattened, the inspiratory limb stays normal. So look at the inspiratory limb. If it is flat, think the upper airway, not the lower airway. COPD never flattens the inspiratory limb. This is critical visual clue that saves you from misdiagnosing the tracheal stenosis as asthma. So here are three quick scenarios to test yourself. Number one, we see a 68-year-old smoker, 40 packs of cigarettes, progressive dyspnea. The PFT show that the FEV1 is 55%, the FVC is 70%. FEV1 over FVC is 62%, TLC is 110, and DLCO is 45%. The FEV1 over FVC is low, so indicates obstruction. The TLC is high, so air trapping. And the DLCO is very low, so destroyed alveoli. We see this is COPD with emphysema. Of course, so this is COPD with the emphysema. So we should start the LAMA plus LABA and add the inhaled corticosteroids if frequent. Scenario 2, we talk about 55-year-old with dry cough, clubbing, Velcro, crackles. We see FEV1 over FEV1 70%, FVC 65, FEV1 by FVC 78, normal. TLC is 72% less than 80, so restrictive. DLCO, we see it is 48%. So here we see FEV1 over FVC to be normal, the TLC to be showing restrictive pattern, and the DLCO is very low, showing the intrinsic type of restriction. So this is likely the interstitial lung disease or the idiopathic pulmonary fibrosis likely. So we should order the high resolution CT and consider the antifibrotics and refer for the transplant evaluation if severe. Again, so 42-year-old obese woman, mild dyspnea on exertion, we see FEV1 over FVC to be 82%, the TLC is 78 and DLCO is 95%. FEV1 over FVC is normal, TLC is mildly low, but the DLCO is normal, so we can say this is obesity related and it has extrinsic restriction. So now we talk about the key takeaways, what to remember when you open the pulmonary function test report. So number one, the FEV1 alone means nothing. Always look at the ratio. So FEV1 over FVC less than 70% obstruction. The airways are the problem. FEV1 over FVC normal or high plus low TLC. This means this is restriction. The lung is small. The TLC less than 80% confirms the restriction. So do not call it restriction without measuring the TLC. That's a golden point that we all should remember, because most of the times we just see the report of FEV1 by FVC ratio and we determine that it is obstructive or non-obstructive restrictive pathology. So the number 5, we see DLCO low in the restriction. Intrinsic lung disease, DLCO is normal in extrinsic. Obstruction, scooped flow volume loop, restriction miniature loops. The bronchodilator response separates asthma reversible from COPD. Mixed pattern is seen FEV1 over FVC less than 70, TLC less than 80. You should treat both. And the upper airway obstruction flattens the both limbs, different from the COPD. So when in doubt, you should do FEV1 over FVC, then the TLC, and then DLCO. These three numbers make up the one single diagnosis. So here is the one-page algorithm. We should keep this in our mind. So step 1, FEV1 over FVC ratio less than 70%. This means obstruction. You should go to step 2A, greater than or equal to the 70%. This shows no obstruction, not restriction. So go to step 2B. So the step 2A, what is step 2A? The obstruction is confirmed here, so look for the TLC and DLCO. The TLC normal or high plus DLCO is low. This is emphysema. The TLC normal or high. The DLCO is normal. This indicates the airway pathology, chronic bronchitis or asthma. The bronchodilator response If it is greater than or greater than 12% and the 200 milliliter above the baseline, this is asthma. The both criteria should be met. So this step number 2B, if there is no obstruction, then look for the total lung capacity first. TLC less than 80, this confirms our restriction. Go to the step number 3 directly. Then if this TLC is normal after there is no obstruction, you should look for the pulmonary function test and non-pulmonary function test cause of the dyspnea. The step 3 restriction is confirmed, so look for the DLCO. If DLCO is low, it is intrinsic pathology. If DLCO is normal, it is extrinsic pathology. So this algorithm prevents two most common errors. First one, calling COPD restriction because FVC is low. Calling the interstitial lung disease normal because the FEV1 is normal. So three numbers, no guessing. So here are all the references that can help you, and thank you everyone. That's all for today. If this helped you, hit the like button, share with a friend who look at the PFTs and panics. Subscribe to the GSM admin for more content like this. Remember, we do not just study medicine, we breathe it. So thank you and see you all in the next video.